brief introduction, like who is presenting, and I see two
Sir,
Naveen Reddys, I think.
I'm Naveen, sir. I'm from
Okay,
Guntur Medical College.
okay, hi,
I mean, I've met you many times in Neuro Club.
okay, okay,
Yeah,
okay, hi,
Ashwini's
hi, Naveen.
immediate senior batch. Yeah.
Okay, okay.
You asked me questions when I was presenting in Neuro Club.
Okay, okay, okay. Yeah, Naveen. Okay, fine, fine.
Yes, sir.
So
Okay.
now who is going to present?
Sir, I am going to present, sir.
Yeah, uh,
Sir, I'm
your name
DNB
is?
resident. Yes, I am a DNB resident, medicine resident from Warangal.
Okay, your name is Naveen.
Yes, sir.
Okay, okay. So I got confused. So two Naveens were there. So I thought, okay, fine. Then we'll
Both
start.
presenter and moderators are Naveen only.
Naveen, yeah.
Yeah.
Fine, yeah.
Okay. Right. You
Fine,
can
Naveen.
start now.
We'll
Yes, sir.
start.
A
Should we
45
switch on
year
the videos or is it fine?
sir.
Videos, should we switch on the videos? Video. I mean, the cameras. Not
Actually,
necessary. Yeah, it's fine. It's fine. Yeah,
ఇంతమంది
you can proceed.
Yes. A 45-year-old gentleman, Mr. XYZ, resident of Warangal, who is a farmer by occupation, belonging to upper lower socio-economic class, was brought to neurology department by his wife and son in a wheelchair with a chief complaints of pins and needle sensation in both lower limbs below the ankle since 4 days and weakness of both lower limbs since 3 days. Patient was apparently asymptomatic in his usual state of health 15 days back, and he could walk around without any assistance and was able to do his regular farming work and daily routine activities without any discomfort. Patient noticed pins and needle of prickling sensation in his both lower limbs below the ankle level, equally in both lower limbs since last 4 days, which was insidious in onset, remained static for the last 4 days. No history of similar sensation above the knee level or over the rest of the body. Patient is able to appreciate the sensation of clothing over the body and is able to differentiate hot and cold water during bathing. No history of cotton wool sensation while walking and no history of band-like sensation over the body. Pins and needle sensation is present all throughout the day and no history of sharp shooting electric shock-like pain while straining, coughing or bending. And since last 3 days, patient noticed sudden onset of weakness of both lower limbs, which he noticed while getting up from the bed early in the morning. Patient was able to sit in the bed from supine position, but had difficulty to get up from sitting position, for which he could do it with assistance of his wife. Patient even had difficulty to walk, like he felt like he was buckling, and could only walk to bathroom with assistance. Patient noticed difficulty to get up from squatting position in washroom, and he could get up with support of wall by himself on the first day, and completely unable to get up from squatting position even with the support of the floor since last 2 days. Patient had mild difficulty to guide the foot into the footwear, but severe difficulty to grip the footwear with the toes, and noticed slippage of chappal without awareness. Patient did not have any weakness in turning side to side on the bed and is able to get up from supine position without any discomfort. No history of difficulty in combing his hair, buttoning and unbuttoning his shirt, mixing food with his fingers. No history of diurnal variation of weakness in his both lower limbs. No history of tightness or heaviness of limbs. Instead, he felt his lower limb as loose and with no adequate strength to walk. No history of fasciculations or wasting. No history of bladder or bowel disturbances. No history of back pain. No history of profuse sweatings, dry skin, or unpleasant awareness of his own heartbeat, or sexual dysfunction or giddiness on standing. He is able to perceive smells normally and has normal vision with no history of double vision. He is able to chew food properly and able to perceive sensations on face normally. No history of pulling of food to one corner of the mouth and no deviation of angle of mouth and is able to close eyes normally. He is able to hear sounds normally and no history of giddiness. He is able to swallow foods without choking and has normal voice. He is able to turn head side to side and is able to make food bolus within the mouth efficiently. On asking, the patient had 2 episodes of semi-solid stools for 1 day, approximately 15 days back, and it resolved spontaneously. No history of fever or abdominal pain or blood in stools during that episode. No history of seizures, headache, weight loss, trauma, or recent vaccination. No history of breathing difficulty. No history of calf pain with swelling, bed sores, or chest pain. Past history, no history of similar complaints in the past. Patient is a known diabetic since 8 years and is on oral medication for diabetes, but has not checked sugars and not consulted doctor for more than a year. Patient is a known hypertensive since 5 years and is on regular oral medication. No history of thyroid illness, bronchial asthma, seizures, cerebrovascular accident, or coronary artery disease. Family history, patient is born out of non-consanguineous marriage and has no history of similar complaints in any of his family members. Patient consumes mixed diet, has a normal appetite. Bladder and bowel movements are regular. He consumes alcohol regularly, approximately 2 units per day since last 15 years. Patient is a reformed smoker, stopped smoking since last 5 years, average of 2 pack years in his lifetime. Sleep is adequate, no history of high-risk behavior. Treatment history, patient is on regular oral medication for diabetes and hypertension. Patient has come to our hospital first for these present complaints and hasn't taken any treatment elsewhere. Summarize, my patient is a 45-year-old gentleman, is a chronic alcoholic and reformed smoker, who is known diabetic and hypertensive, has presented with history of 2 episodes of semi-solid stools 15 days back, followed by insidious onset of pins and needle sensation since 4 days, and weakness of lower limbs since 3 days. He has acute neurological illness with motor involvement in the form of acute flaccid paraparesis, and sensory involvement in the form of distal symmetrical neuropathy, with no cerebellar, autonomic, or spine involvement. So I thought of differentials as acute inflammatory demyelinating neuropathy or acute polyneuropathy, because could be diabetic polyneuropathy or alcoholic polyneuropathy. Shall I continue?
We'll wait here. Sir will ask you some questions and then you can proceed. Okay. Yeah.
Yes.
Because it's DNB, mostly it will be history related only. Okay. So we'll ask you questions. Yes, sir will start.
Okay. Shall we start analyzing the first symptom?
Yes, sir. Yeah. His first symptom was pins and needle sensation or tingling sensation, mainly complaint in both lower limbs, which was symmetrical and below the ankle level since last 4 days, sir.
Okay. So what do you think of this symptom?
So this is a positive sensory symptom.
So can you analyze this symptom?
Yes, sir.
Okay.
Like this pins and needle sensation, it can be at the root level, or it can be at the plexopathy, or it can be at the root nerve level, or it can be at the tract level, sir. Actually, there are no root symptoms because the patient is not having increase of pain in like sharp shooting pain on straining or cupping or bending, and it could be either neuropathy or it could be either plexopathy. It cannot be posterior column because patient doesn't have any band-like sensation, and so probably it could be nerve level or at the plexopathy, sir.
So why do you think it is peripheral nerve, and why do you think it is plexopathy? Why do you think it is peripheral neuropathy? And what are the points that is favoring peripheral neuropathy, and what are the points that are plexopathy?
Yes. Neuropathy usually starts at distal onset, and this patient has distal symmetrical sensory involvement, and it doesn't have usually any specific characteristics. It doesn't have any exacerbating or relieving factors. And plexopathy, the pain would be in the center of the plexus, and it radiates along multiple nerves. So because it is in the both nerves, the possibility of neuropathy or plexopathy is possible in this scenario.
So out of these two, what do you think is the first possibility?
Neuropathy, sir.
It is neuropathy. Okay, fine. Neuropathy because it is
distal symmetrical.
Distal onset.
Yes.
Okay.
Yes.
So why do neuropathies have distal onset of symptoms?
So usually neuropathies are 2 types: length dependent and axonal. So length dependent, usually the long axons are involved first, followed by the short axons. Axonal neuropathy, length dependent neuropathy.
So you think that this is axonal neuropathy or a demyelinating neuropathy?
So because it's of a very short history, sir, like very acute history, so probably I think of demyelinating neuropathy.
Okay. So why is short histories favor demyelinating neuropathies? So there are chronic demyelination neuropathies.
Yes.
Also.
Yes, sir. Chronic demyelination.
So why do you think then? Why did you say that? Since the course is acute, see, the course cannot tell you whether it is acute or whether it is
Demyelination
or axonal. Okay.
Axonal.
Course will tell you the rate of progression. That will give you the idea about the etiology predominantly.
Yes. Yes.
Okay. So in case of in general in neurology, course the rate of progression of the disease will give you the idea and the information regarding the etiology of the illness. Okay. So
Yes.
in case of neuropathies, there are chronic as well as acute demyelinating neuropathies. So
Yes.
in this case, you cannot tell acute, so it is demyelination. So there, what is the another way asking? What are the features of demyelinating neuropathy and what are the features of axonal neuropathy?
Yes, sir. So axonal neuropathy usually has predominant wasting, and axonal neuropathy usually it's distal more than sensory.
So we are talking about sensory, right? We are talking about sensory neuropathy.
Sensory. Yes.
So first we'll talk about sensory. So we are talking about the sensory symptom. So
yes, sir.
First we'll talk about the sensory this thing. Okay.
Yes.
So sensory symptoms, how to demyelination and axonal.
Yes, demyelinating neuropathy usually predominantly involves the nerves with more myelin, sir. Probably it will involve proprioceptive neurons predominantly than compared with pain and temperature and touch
So
fibers.
they'll have a loss of proprioception. The patient did not have a loss of proprioception.
Proprioception. Yes.
So and what else?
And,
the type of paresthesias also can differentiate whether it is large fibers. So basically what we're trying to say is demyelinating neuropathies involve large fibers.
Yes.
Right? So what are the what sensory information is conducted through large fibers in peripheral?
Vibration, proprioception, and the posterior vibration, position sense, and this
fine touch.
Fine touch, yes.
Okay. So
yes.
Basically, if a patient complains of burning sensation, okay. Paresthesias in the form of burning sensations, probably you can think it is an axonal neuropathy because burning sensation is a symptom of small fiber neuropathy.
Small fiber neuropathy. Yes, pain and temperature.
This patient does not have a burning sensation. So probably he does not have a small fiber neuropathy, maybe a large fiber neuropathy. So that is why maybe you can think of a demyelinating neuropathy in this patient. And what else? Can you anything about distribution of the sensory symptoms?
Yeah. So clinical, the course of the illness and the distribution also can help you in differentiating whether it is demyelinating or an axonal illness.
Yes, I'm not sure about it.
So if it is symmetric, generally it tends to be a demyelinating illness. And generally axonals are chronic and long-standing, whereas demyelinating illnesses are acute and symmetric.
Yes.
And as you told, posterior column like vibration and proprioception are more than these pain and temperatures in demyelination. Yes. Whereas in axonal, it is more of what we call pain and temperature involvement than vibration and proprioception. And one more right point, even unlike sensory, you told there's wasting of muscles.
Yes.
In axonal, right?
Yes, sir.
Yeah, even that is correct. Okay.
Okay. So now, what do you think? It is an axonal neuropathy or a demyelinating neuropathy?
Demyelinating neuropathy, sir. Because it was symmetric and it involved large fibers. It did not involve
large fibers. Yes. But patient had distal predominant symptoms, no?
Yes, sir.
So distal predominant symptoms are usually features of axonal neuropathy.
Axonal neuropathy, yes.
So distal predominant symptoms are usually axonal neuropathies. But otherwise, clinical picture looks like a demyelination. So you just have to hold your thought here. You can think that maybe both demyelination and axonal are there in this patient. Okay. Or maybe only the demyelination is involving the distal nerves. Okay. So you could you need not fix your you need not have a
Diagnosis.
exactly. So you need not at the first symptom and at the first analysis and in the history itself, you need not. There is no necessity that you have to have a diagnosis or a this thing decision. You don't have to do that. So you can always tell that probably the patient has both. Probably patient has axonal or probably patient has demyelination only, but you have to tell your possibilities. So first, I think he probably has more likely to have a demyelinating neuropathy,
Myelitis. Yes.
or maybe then probably demyelination plus axonal neuropathy he may be having, or maybe axonal neuropathy. We don't know. We can still next symptoms when I analyze or when I examine, I might know. You might know. Okay,
Yes.
so this
Yes.
is the right.
And
Okay, so
next,
no,
like, because they're at
yeah,
MD level, they'll
uh,
ask you what are positive and negative phenomena. What are positive symptoms in sensory and what are negative symptoms? Just name
Pos-
them.
Yes, sir. Tingling sensation, burning sensation is a positive symptom, sir. Like
Uh-huh.
negative symptoms would be numbness and cotton wool sensation would be a negative symptom.
autonomous
Cotton wool
sensation
is
you're
a,
telling.
yeah,
You're telling it is a sensation. No, if you're sensing it it must be
it
positive.
is
No?
cotton wool, tingling, and paresthesias. Spontaneous paresthesias are
Okay.
generally positive. Not generally, they are positive. So negative.
There.
Examiners tend to ask you more of negative because we stop at numbness. Any other negative neuropathic what do you call this thing you have? Negative phenomena?
Analgesia, sir. Like
Analgesia, patient won't tell no. It's not a symptom. Wash basin attacks.
wash basin attacks.
Yeah, ataxia.
Okay.
Okay, yeah, fine. Okay, proceed.
Yes, and the second symptom is weakness of both lower limbs since 3 days. It initially started as proximal weakness, sir, because it was sudden in onset, and when he tried to get up, he was unable to get up. So, and later also, when he went to washroom, when he has no difficulty in squatting, but when he tried to get up from the squatting position on initially day one, he could get up with the help of the floor. Day 2, day 3, it worsened. He couldn't get up from the squatting position. He required an assistance, and he also had buckling episodes suggestive of proximal onset weakness, like proximal onset, which again later also had distal weakness also. Predominantly proximal more than distal weakness, which was acute in onset.
Hmm.
So again, it could be a neuropathy, demyelinating neuropathy is possible, sir. Or it can be also LMN, because LMN also starts with
No, even
proximal more than.
demyelination is element.
Yes, sir.
Don't mix
Sorry, sir.
up terms. Okay, anything
Yeah.
which is what is an element? Here, examiners will catch you. What is an element?
The lower motor neuron, it's from the anterior horn cell till the neuromuscular junction at the muzzle level. So
Okay.
element usually it is usually distal more than proximal, but demyelinating neuropathy is like proximal more than distal.
Okay.
Predominant onset of weakness.
Okay. So you say because he's having difficulty in getting up from squatting, it is proximal in onset.
Proximal more than distal, yes, sir.
Okay, okay, okay. Where else do you see a proximal weakness?
Proximal. We usually see demyelinating neuropathies is one, sir, and others it can also be seen in myopathies. Also, it's like proximal more.
Basic. Yeah, yeah. Okay, okay.
Okay, can you just scroll up a little? I just want to point out something. Okay. The motor description, motor history of presenting illness, motor part. Okay. So you said patient patient was able to sit in bed, sit up in bed from supine position. So
Yes,
why did
like
you say that?
so actually to see if there is any truncal weakness, like because it
Truncal.
was yes, sir,
So
but patient did
patient.
not.
So what
When I
muscles do we use when we sit up from supine position?
extensors of the spine extensors of the spine, sir,
So when you're sitting
Extensors.
up from supine,
supine position.
when you're doing basically crunches, What muscles do you use?
You're coming forward, no? You're going more anterior. So what muscles will you use?
So where did you ever do that crunches in gym?
No.
You never did చేయలేదా నువ్వు ఎప్పుడు? So once you can try. So basically your anterior abdominal muscles you use. Okay. So when you're sitting up, but see, if you had ever done a crunch, then not just the anterior abdominal muscles, you will have to fix your legs. Okay. So we usually ask somebody to hold our legs. Okay, we usually ask somebody to hold our legs when you're doing for the first time or if you are a beginner. So why do we do that? Because we fix the legs and we use our iliopsoas muscles. Okay, so iliopsoas muscles to flex the hip. Then your trunk will come up. Okay, so predominantly muscles that we use to lift our trunk from the floor is rectus abdominis, and to completely sit up, it is your iliopsoas. So why is it important? Why is this particular history important? Because you made it a point. That's why I'm having a discussion. Because it is supplied by L1 and L2. This will give you, if you are talking about a myelopathy, it will give you the level of spinal cord involvement. Okay. This is a one specific symptom that will tell you patient is not able to sit up from supine position, then he has like a level at above L1 level. So now we know that L1 level he is able to sit up from, so L1 roots are fine. Okay, but he is not able to get up from sitting position, but he is able to sit now, but he is not able to get up. So what muscles do you use to get up from sitting position?
So it would require erector spina, it would require hip extensors, also it require knee extensors.
Knee extensors. So now you tell me what, if you said it is a, so what do you think, what is the anatomical localization, weakness of hip extensors and knee extensors? And you have to stabilize your ankles also if you have to get up from sitting position. So now we have anterior thigh muscles and posterior thigh, basically gluteal muscles involvement. So what is the anatomical localization? Another way, if you think it is muscle, then it is muscles. We know what muscles are involved. If you think it is peripheral nerve, what peripheral nerves are involved? So in other way, what are the root values of your knee extensors and hip extensors?
Yes,
this is important.
Yes, so knee extensor, it's a quadriceps which has a femoral nerve L3 supply. And gluteus maximus is a predominant hip extensor. So it would be around L2, L3, so L2 and L3.
Hip extension. So one thing is, when you are talking about when you are when you are approaching a neuropathy, you need to know the nerve supply and the root supplies. Okay. Only then you will be able to localize it and you will be able to diagnose properly. So anterior thigh muscles are supplied by L2 and L3 and L4 also. Okay. And hip gluteal are supplied by L5 and S1 predominantly. Okay. So now we know that from L2 to L5 all are involved. Okay. So the root values of the muscles from L2 to S1 all are involved. But see, now we can see predominantly at the start he had symptoms in the proximal. Okay. So when patients are having proximal symptoms at the beginning of the illness, then it cannot be nerve. Okay. Usually nerves will have onset of the symptoms with the okay. So either it should be muscles, like sir told, or it should be what can it be?
Radical levels.
Whether it can be radical or sometimes plexus.
Yes.
Okay. So radicals will be first. this thing,
Yes.
and plexus will be second. So why
Yes.
plexus will be second? Because we have lumbar plexus and we have sacral plexus.
Sacral
It
plexus.
has to involve a pathology
Both.
should involve the entire lumbosacral plexus, because we have lumbar plexus involvement also, and anteriorist femoral nerve and also belong to the lumbar plexus, and sciatic
Hip
nerve and
extension S1 is all
they all
about
belong to
sacral.
the sacral plexus. So you need to have a pathology that will involve all the plexus, and usually plexus you, and then we need to approach. Now we need to think about the, when you're approaching a patient like this, we need to think what etiology can cause such. See, this patient probably has a JPS. It could be a clear-cut case, but you need to think whether a plexopathy can involve both the sides.
Yes.
Whether a plexopathy, usually does it involve
Isolated plexopathies.
Isolated.
Do they simultaneously occur?
So usually they don't occur. So you need to have a pathology on both the sides, and it should involve both the lumbar and sacral plexus, and which seems unlikely. Okay, so probably it is in the radicals. So radicals means you have to go inside the vertebral column. Okay, the pathology is in the vertebral column near the radicals. Okay, so now sensory symptoms. I told you to hold your thought there when you are discussing the sensory. Okay, sensory symptoms patient had distal predominant sensory symptoms, and motor symptoms patient had proximal motor symptoms.
Yes, predominantly proximal.
Okay,
yes,
predominantly proximal motor. So motor symptoms are looking like a radiculopathy, and sensory symptoms are looking like a neuropathy. So now we are speaking about a
Radiculoneuropathy.
Okay,
yes.
so this is how we approach this patient. So he has symptoms of radicular involvement, and he has symptoms of peripheral nerve involvement. So probably you are looking at a pathology which is involving radicals and peripheral nerve.
Yes.
Okay, so you are dealing with the radiculoneuropathy, and you have a course which is very acute. So you are dealing with the acute polyradiculoneuropathy. Whether it is demyelination or axonal, we still have not yet confirmed it, but it looks like it is looks like a demyelin, because most common are demyelinating neuropathies in our clinics. So probably we will tend to tilt towards a demyelinating neuropathy, but a wise clinician will not commit at this point. Okay, we will still have to examine the patient, we'll still have to investigate the patient. You just have the possibilities in your mind. Now we are dealing about a radiculoneuropathy. Okay.
Yes.
For suppose if this patient had some difficulty in getting up from lying position.
Yes.
So what does it indicate?
The truncal muscles are also involved. So like the ascending.
So if the paraspinal muscles and all are involved, you can think above the level of plexus. The involvement in LMN is above the level of plexus if paraspinals are involved.
Yes.
Okay, if it is an isolated plexopathy, you don't expect paraspinal muscles.
Yes.
Okay. And just a quick revision, because we are like medicine level. Hip flexion, what roots?
I'm not sure about this.
No. L1, L2 will be hip flexion.
We just discussed about this, no? Because L1 told you L1 is helpful in flexion
hip
to
flexion.
6 months.
Yes.
Okay, so always remember L1, L2 is hip flexion. L2, L3 is hip adduction. L2 means add. So L2, L3 is hip adduction.
Yes.
And L3, L4 is knee extension. L4, L5 is tibialis anterior. Okay?
Yes.
Okay, fine. Okay. Next, you can quickly skip the negative history. And why sexual dysfunction in 3 days, man? Don't include unnecessary things.
Yes.
Okay. And even don't mention about fasciculations. Don't use what do you call medical terms in your history. On these age-old examiners, no, they tend to be very specific.
Yes.
You can write the word twitching if you want. So there's no history of twitching. It's good that you wrote that, but use non-medical terms. Okay.
So can you expect, if you are dealing about the acute neuropathy, can you expect fasciculation in this patient?
No, sir.
No, then you don't have to write. No.
Yes.
For the acute neuropathy here.
Yes.
Okay.
And one more thing. I remember 2 episodes of semi-solid stools for 1 day. Adiguda is not needed, I guess, sir.
Etiology, it is essential.
He,
Include the
yeah,
history about the etiology. You need to. I think it is fine, because see, in the history, negative history, you always need to mention the history regarding the etiology. They need to know that you have made an effort to find out the etiology from the history. So that I think it's fine.
no, only 2 episodes won't count, but I guess I was like,
2 episodes. Okay,
only
okay.
2 episodes. That is
Okay.
2 episodes is normal, man. Up to 4 times a day is normal nowadays.
Yes.
Fine.
Okay.
Fine.
Yeah. He had multiple
Okay.
episodes. You can mention that.
Okay.
Okay.
So now, no, so polyradicular neuropathy kada. So now now you have localized, so probably demyelinating, could be axonal also. So maybe flexopathy also.
Yes.
Kada. So from our history, we narrowed our differences to so then you need to make an effort to get the etiology from the history. Okay, so for that you need to know the etiology for these things. Okay, for polyradicular neuropathies ki or flexopathies ki etiologies. So at the end of the day, you will read the etiology. So if you did not make any effort to get an etiology from the history, the futile effort together. So aim effort చేస్తాను హిస్టరీ తీసుకోవడానికి అంటే ఈ అదర్ డిఫరెన్షియల్స్ రూల్ అవుట్ చేసుకోవడానికి ఇటియాలజికల్ డిఫరెన్షియల్స్.
So
polyradicular neuropathy. Indirect sir adugutunna adi.
Yes, sir. First possibility is Guillain-Barré syndrome, sir.
పాసిబిలిటీస్ కాదు, ఇటియాలజీస్ చెప్పు. వాటి గురించి ఏం హిస్టరీ తీసుకున్నావో చెప్పు.
So for Guillain-Barré syndrome, I asked if there was any preceding onset of respiratory or GI illness, sir.
Okay.
Or it could be any other illness like cytomegalo, like any illness which can precipitate a recent history of like I've asked if there is any recent history of vaccination that can also cause Guillain-Barré syndrome. Or for the neoplastic, like acute history, but for neoplasms, I asked history of any weight loss. And for metabolic causes, I've asked about the negative history of diabetes, like how the sugars are controlled. Was he regularly visiting his doctor for checking sugars? And so that was, and like if it is vitamin related neuropathies, I've asked about the diet. He consumes mixed diet.
So now it is an acute polyradicular neuropathy. So usually acute inflammatory and infective.
Infected, yes.
Okay. Sometimes metabolic, but peripheral nerve lo metabolic inta fast undav. CNS lo aithe if acute course ante you think about metabolic also.
Yes.
Okay. So now infective and inflammatory etiologies, polyradicular neuropathies. GBS.
So yes, sir. Other infections like Lyme's disease, which can cause
neurological. First the common ones first.
Cytomegalovirus.
Okay.
HIV, sir, human immunodeficiency virus.
Okay.
Campylobacter jejuni, that's GBS, and mycoplasma.
Only GBS adutunala sir, or like in general polyradicular?
GBS and polyradicular.
So inkoti most common bread and butter for general medicine.
Tuberculosis.
Pulmonology and general medicine.
Tuberculosis.
Tuberculosis.
Yes, CMV, tuberculosis, Lyme's.
Lyme.
Okay, fine. Inflammatory causes, same thing.
Inflammatory causes, it can be vasculitis, possibly.
Game vasculitis.
Like any polyarthritis nodosa or systemic lupus.
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 Okay.
So systemic vasculitis. అంతే కదా.
Yes.
Like SLE, Sjogren's,
Jogger's.
mixed connective tissues. Okay, fine. Sarcoidosis sometimes. Sarcoidosis, polyradiculoneuropathies. So history regarding these things is missing in your thing. Negative.
Okay.
Fine. Next, sir, we'll go forward. Huh?
Yes, sir. Yes. As you said.
Okay.
General physical examination. Patient is conscious, cooperative, and obeying commands. Patient is moderately built and nourished. Heart rate of 98 beats per minute, regular rhythm with normal character and volume, normal condition of vessel wall, and pulse is felt in all peripheral vessels with no radial or radiofemoral delay. Blood pressure of 130 by 70 in left upper limb in supine position, and there is no postural hypotension. Saturations were 96% at room air. Patient is afebrile. No pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. No nerve thickening. No external markers of atherosclerosis. No visible neurocutaneous markers. No signs of nutritional deficiency. Nervous system examination. Higher mental functions. Patient is conscious, alert, well oriented to time, place, and person. Patient is right-handed and finished formal education up to 5th standard. Memory is intact. Language and speech were normal. Intelligence is normal, and attention span is also normal. Cranial nerve examination, I felt normal, sir. Like after examination, I couldn't find any abnormality in cranial nerve, all the 12 cranial nerves.
Okay. Positive findings.
Yeah, motor system. Patient was lying supine comfortably on bed with shoulders adducted and in neutral position. Elbows extended and wrists and fingers flexed. Hips are abducted and knees extended. Knee plantar flexed and foot inverted. Bulk was normal, so no wasting compared to opposite side. Tone, upper limb flexors, extensors were normal, but lower limb flexor and extensors, it was hypotonia. Power, upper limb, the shoulder joint was 4/5. It was like 5 minus. It was not complete normal power in both upper limbs. Upper limb, like at shoulder joint and elbow and wrist joints. Lower limb at hip and knee joints, it was around 3/5. Lower limb at ankle and toe, it was 4/6. Proximal weakness more than distal weakness. And hand grip in both sides was approximately 80%. Truncal power, he could only get up when examined with the support of the hands only. So he couldn't get up without the hands keeping on the bed. Reflexes, it was generalized areflexia. Biceps, triceps, supinator, knee and ankle were absent. Superficial reflexes, abdominal was absent, and plantar, it was mute side, was equivocal. No involuntary movements. Coordination in the upper limb, normal finger nose test and finger tapping test, but in lower limbs I couldn't do because of weakness. Gait, patient is walking by dragging both the lower limbs over the ground. Mostly is unable to walk, but could walk less distance by dragging both lower limbs over the ground. Sensory system, like normal pain and temperature sensations. Position and vibration sensations are normal. Cortical sensations are also normal. Timed vibration sense at ankle levels and anterior superior iliac spine, it was less than 20 seconds, and it was also less than 20. It was less when compared with the examiner. He felt the vibrations for less duration when compared to examiner. And dynamic joint sense is unable to make out the minute joint sensation, joint movements. Cerebellar examination was normal. Romberg's test is negative. No signs of meningism. No spinal tenderness. Other system examination, cardiovascular, like first and second heart sounds were heard with no murmurs. Respiratory system, bilateral normal vesicular breath sounds. Per abdomen, it was soft, non-tender, and bowel sounds were heard. Diagnosis, it was an acute flaccid progressive paraparesis, proximal more than distal, with distal symmetrical sensory neuropathy, involvement of truncal muscles and also upper limb. Anatomical localization, it is polyradiculoneuropathy. Pathology being demyelination. Possible diagnosis, Guillain-Barré syndrome, acute variant being acute inflammatory demyelinating polyradiculoneuropathy.
Okay. General examination. Let's go there. Okay. Would you expect a change in this patient in your general examination? Now, because you landed into a diagnosis after your examination.
Yes.
So, what changes would you see? Heart rate lo emana difference? The patient be having any heart rate differences? If so, why?
Usually in if autonomic nerve component is involved, there can be resting tachycardia is expected, sir.
Okay.
And
Why is your SpO2 important? Why is your respiratory rate important?
Because it also involves the muscles of respiration, so which can cause tachypnea. Respiratory rate would increase, and if there is a diaphragmatic palsy, there can be decreased saturations on rooms.
RR mentioned.
Yes.
Make sure you mention, especially in the case of GBS, you
Yes.
need to mention your respiratory rate. Okay.
Yes. Yes.
Okay. Fine. Next. And postural hypotension, Chusava. He's unable to stand. You mentioned postural hypotension and rhombugs. Don't
No,
come
sir,
in such mistakes. Could not be checked and asked, okay, or if you stop mentioning also, it's okay.
Okay.
Just mention the blood pressure, millimeters of mercury in right upper limb. Okay. That would be enough.
Yes.
Okay. Higher motor functions.
So patient was conscious, alert, and well-oriented, time, place, and person. Like,
Okay.
I didn't find
Do
higher
you
mental
expect a
functions.
change in a polyradiculopathy with heavy?
No.
No. If there's an infective polyradiculopathy,
Yes.
like for suppose Lyme's and tuberculosis, they generally tend to have an overlap.
Yes.
Okay. Fundus, మీరు చెక్ చేస్తారా? Is it compulsory for you? Fundus examination mentioned.
Okay.
Eye.
Yes, sir. Yes.
Would you expect any change?
This raised ICT if it is associated with any infectious etiology, sir. Papilledema.
Papilledema can be seen in GBS because you'll have high protein levels.
Yes.
Okay. So, what's the most common cranial nerve which is involved?
So in AADP variant, 7 cranial nerve is most commonly involved. So bilateral facial nerve is 50% of the times involved.
So here you say upper limb is involved, lower limb is involved, but facial nerve is then not involved. Knee patient.
Yes, sir.
Okay. Sir, Ram sir, మీరు ఏదైనా అడిగితే అడగండి సార్.
లేదు you continue, sir.
సార్ మీరు నవీన్ అని చాలు. Okay.
If it is CIDP, the lower cranial nerves, like Miller-Fisher variant, lower cranial nerves are usually involved, sir, like 9.
Just because you mentioned Miller-Fisher, what's the triad of Miller-Fisher?
Areflexia, ophthalmoplegia, and ataxia.
Okay. So anything more about how do you check your 7th cranial nerve?
So 7th cranial nerve, first we'll check the gross morphology, sir. If there is any asymmetry in the facial, like if there is any facial asymmetry, followed by the motor examination, followed by sensory examination, reflexes and secretions, like for
reflexes. What reflexes would you see for your 7th nerve?
Corneal and conjunctival, like it has referent being 7th nerve.
Acha. Okay. Okay. How do you test your? Tell me the muscles which you test in your facial nerve.
Facial nerve
because
first,
you suspect an LMN lesion, because this is a radiculoneuropathy.
Yes.
So, how do you test facial nerve? What do you know? Patient is in front of you. Examiner asks you to test the facial nerve.
We'll ask the patient to frown, sir, to see for the presence of wrinkles over the face. That would test the occipital belly of the cheek. Yeah. That would test the frontalis muscle,
Yes.
sir.
Frontalis.
Frontalis.
Not occipital belly. Okay.
And we'll ask the patient to clench his teeth if there is any deviation of the angle of mouth. And also we'll ask the patient to close his mouth and blow, so to chest, and we'll see if the air is leaking by tapping on the cheek. And
So come from top to bottom. Eye closure.
eye closure, orbicular is ocular. Yes, we'll ask the patient to
Oculus.
close the eyes as tight as possible.
Okay. You purse your lips and Tara.
And whistling, sir, for buccinata.
Okay.
And clenching, the platysma, I will ask the patient to clench his teeth and flex, extend the neck. So
You check
for
both the
platysma,
facial nerves. Yeah, many a times GBS patients tend to come with bilateral facial pulse. Yeah. And how would you ask the clinical history about facial nerve palsy? What would the patient say?
if there is any drooling of the foot to one corner of the mouth or drooling of
Okay.
saliva, unable to close the eyes. And if the patient noticed any asymmetry by there's a deviation of angle of mouth.
No, both sides, if it is there, he'll be unable to remove what?
Bell's phenomenon still present in
Food stuck in his mouth, he'll not be able to easily manipulate.
manipulate. Yes.
Okay. And okay, so in your patient, because cranial nerves are normal, we'll proceed with motor examination. Okay.
Yes.
Okay.
There's no wasting of the
So
muscle.
you don't expect any wasting?
Yes. So there is a hypotonia in the lower.
Hello. Yeah. So what was the attitude? Can you come down? Attitude. Yes.
The lower limbs, it's abducted, sir. Hips are abducted and neutral flexion and rotation. Knees extended. Knees, ankle plantar flexed and foot inverted, like typing.
So what was the power in the ankle?
4/5, sir.
Ankle also
Yes.
4/5.
Yes.
Okay. Fine. Then probably you don't expect any change in the attitude of the foot. Okay. Fine. Then next tone.
Tone, it was hypotonia in the both flexor and extensor compartment of the lower limbs.
Okay. So how do you check tone?
We check.
Define tone and tell how do you check tone.
Tone is a degree of resistance that is present in a muscle at a rest due to the passive movement across the joint. And while checking for the flexor compartment, we place the hand over the extensor compartment and feel for the tone in the extensor compartment. While flexing the knee, we keep the hand on the extensor compartment and feel for the tone in the extensor compartment. And by extending the knee, we keep the hand on the flexor compartment and feel for the tone in the flexor compartment of the legs. We can do it by flexion extension.
Yes, you're correct. But see, tone you can examine 3 ways. Okay, you can inspect, you can palpate, and you can do a movement and feel the resistance. So when you inspect, what do you inspect?
Inspection, hypotonic muscles would not be so prominent, sir. Hypertonic muscles would be prominent on inspection.
So prominent and not prominent is either hypertrophy or atrophy. What you are talking. Prominence is big. Okay. Not prominent is small.
Small.
So we will be clear with the terminology. So what on inspection, what else do you see when you call a patient there's a hypotonia?
Flabby, sir. That's on palpation.
No, inspection. We are not completed with inspection of the muscles. So the contour will be there. No contour. Usually,
yes, contour is preserved in hypertonia. It is lost in hypertonia.
So the contour is lost. So it will become oval. It will be falling when you lift it. It will be falling, and you see the attitude at the joints. If they are drooping and all, then probably the patient has hypotonia. And then you palpate and see further.
You would see firm and rubbery in hypertonia and flabby and loose in hypotonia.
Yes. Okay. Then, and of course, we'll do the
moment.
So Now, what is hypertonia?
Hypertonia is so hypertonia. It can be like there's an increased tone in the group of muscles, sir. So it can be a spasticity or rigidity, sir.
Or rigidity. So how do you differentiate spasticity and rigidity?
Spasticity is actually velocity dependent. The more faster you do the movement, you can feel the more tone. And spasticity, it is like unequal increase in tone. It is increased in antagonist group of muscles, anti-gravity muscles, than in the gravity muscles. Whereas
So anti-gravity, gravity and all is for the animals. I mean, like the four-legged animals. For them, they have anti-gravity and gravity. For us, it is different. So for us, flexors in upper limbs, extensors in lower limbs. Okay.
Yes.
Anti-gravity word will be because all our muscles are anti-gravity muscles.
Okay.
Okay. Fine.
Yes.
So in the lower limbs.
Yes, in lower limbs.
Extensors, upper limbs, flexors.
Yes.
Okay.
So in
lower rigidity, all of them are equally involved.
Yes, sir.
So any specific maneuver that you do while examining the patient to tell whether it is hypertonia or hypotonia, sorry, spasticity
Rigidity
or
versus spasticity.
While examining the patient has grade 1 of increased tone. That is mildly increased or grade 1 or grade 2. Okay. So
yes.
Now we have to tell whether it is spasticity or rigidity. So what you will do?
Spasticity versus rigidity.
No, you just said velocity dependent. No.
Yeah, the more like the faster the moment we do, like if the tone is increasing, that is velocity dependent. It's spasticity, sir. In rigidity, the tone would be same throughout the range of movement, and it is not velocity dependent.
So what you do is, so treat this phenomena, the spasticity, easily, especially when the patient has mild increase in tone or mild grade 1 or grade 2 increase in tone. So what you'll do is you check for the pronators. Pronators are the best.
Pronator catch. Yeah.
Okay. So you hold the patient's hand like you're giving a shake hand.
Yes.
Then you rotate the
pronate and supinate
elbow. And then you first do it slowly so that you'll feel the resistance, whether there is hypertonia or not. Then you do it fast. Then you will feel a catch at one point.
Yes.
Okay. So if you are feeling a catch, then it is spasticity. If you're not feeling a catch and the entire movement is, there is a resistance, then it is a rigidity. Okay, fine. Next. Power.
Power, sir, it was lower limbs, it is proximal more than distal, and in upper limbs, it is both same in proximal and distal.
Okay.
The reflexes, it was generalized areflexia, sir. Could not elicit even after reflexes.
Even after? What do you call that?
Gender 6 reinforcement, sir.
There are people who ask me spelling of gender 6 also. Okay. Make sure you know gender 6 spelling, okay?
Yes.
Okay.
Superficial reflexes at abdominal were absent. Plantar was equivocal on both sides. Motor, because the rest was a negative.
So why were the abdominal reflexes absent?
It's usually in element, the abdominal reflexes.
Element means what?
So in this case,
so what are the components of abdominal? So it's a noxious stimulus, no?
Yes.
So you give a painful stimulus.
Painful stimulus.
When the abdominal reflexes are absent, what does that mean? Lesion is in the LMN or UMN. What is it?
So it can be absent even at the root level, like.
So it can be absent, but the muscles have to be severely weak.
Severely.
For the LMN, so for the LMN to have an absent abdominal reflex, does this patient have some severe weakness of the abdominal muscles? So how do you test the abdominal muscle weakness?
by asking the patient to lie supine, sir, and without the support of the hands, ask him to get up, like flex, get up from the bed by flexing the knee. Then we can see the muscles that are contracting. So if the muscles are, we can see the visible contractions of the muscle and is able to get up from the bed from supine position.
You have to see and palpate the abdominal muscles while contracting. And then if they're flaccid and weak, you will have that the bulging of the abdomen. Okay, some severe weakness and all. So that is what we see. So
Yes.
does he have severe weakness in abdominal wall?
Truncal power was less than 60%. Like he was able to get up from the bed only
So
by.
what truncal power did you see? I don't know at MD level how they will ask you, but it is better to learn the right way. Correct?
Yes.
So
Yeah.
when you say truncal power, what truncal power you're talking about? And your power chart, no? Can you come down? Then can you scroll up? So shoulder joint, elbow, wrist joint.
All the movements.
This is so you have to specify the movements. What movements? Because
Yes.
see what is the root value of biceps?
1, 2, 3, 5, 6 or L5. C5, C6.
C5, C6. And what is the root value of triceps?
C7, C8. Sir.
C7, C8. So if there is any difference, that we need to know.
Yes. Yes.
Okay, whether they have triceps could be normal. We never know. Okay.
Yes.
So
Yes.
we have to specify it every joint. Okay, and this joint examination at joint is for the actions and joint is for the UMN type.
Yes.
Okay, for element type you have to examine individual muscles, and if you're suspecting a neuropathy, you have to say as a neuropathy, radiculopathy, then radical wise. Okay.
Yes. Yes.
Fine. So this is the right way. Eventually, if you are going to learn neurology, then probably it will help you.
Yes.
So reflexes are all absent.
Yes.
So what does an absent reflex mean?
Problem could be either in the afferent center or in the efferent. So here in the nerve, because
reflex arc, can you tell me what are the components of reflex arc?
So afferent nerve, the reflex center, sir.
Reflex center.
And the efferent nerve.
So what is an afferent nerve?
So which carries the sensation to the.
So you should be able to tell 5 points. You have to do. You should be able to describe what is a reflex arc in 5 or 6 sentences. Okay. So just read it. It is important. Okay.
Yes.
Fine. Then, superficial reflexes. I don't know why abdominals are absent, but you can check once again for this patient.
Yes. Yes.
What is equivocal plantar?
So equivocal plantar, either the reflex can be mute. So like there won't be any toe extension or other toes, the great toe extension, other toes extension, or it can be there is.
So what did you observe that you?
So it was mute, sir. For my patient, there was no.
You can mention mute, Gada.
Okay.
Don't complicate your case. Okay.
Okay. Yes.
Equivocal, you will tell when you did not check the plantars. Okay. Fine. Next.
Sensory
Patient
is.
mute.
Yes, sir.
Sensory, you had intact, what do you call, position and vibration, huh?
Yes, sir. He was able to feel the vibrations, and position. He was able to tell the large movements of the joints, and also like positions. Yes, sir. He is able to tell, sir. But timed vibration, there was.
What is dorsal column sensation? What is spinothalamic sensation? Who's testing spinothalamic tracts now? So you will make an observation, then you will localize later. Okay.
Okay.
You will make an observation whether pain and temperature sensation detect or not. If they are low, intact, then what pattern they are lost. That is your observation. Based on that, whether it is a spinothalamic tract, whether it is a radical, whether it is a plexopathy, or whether it is a peripheral nerve involvement, that we will later
Yes.
find out.
Delineate that. Yeah.
Okay. So you
Yes.
cannot
Don't
write
mention that.
spinothalamic sensations or dorsal column sensations.
Yes.
Mention pain, temperature, GPS, joint position, vibration. You can code that as a subheading and mention the
Then
findings.
mention. That's
Yes.
all.
Yes.
Cortical sensation. Why did you test cortical sensation?
So actually, just
Waste
to
of time. No, such a waste of. You have 1 hour for 1 hour. Final exam.
no, 30 to 40 minutes.
40 minutes. You would test cortical sensations. You will test cortical sensations in this patient. If you have this, you'll
No,
be
sir,
wasting so much time.
not in this patient, but just for completion sake, I guess.
You don't have to.
Okay.
So now you tell me what are the cortical sensations.
Cortical sensations are it is 2-point discrimination, tactile localization, graphesthesias, and like sensory inattention and stereognosis.
Very good.
It's like then. Let's, sir, we'll jump to the treatment part or like. Maybe.
Okay. So it is a progressive, acute flash progressive paraparesis. Fine. Good. Nice. Yeah. So now why so did you like thing was added for your history?
Sir, I didn't get. Sorry, sir, I didn't get.
After examination, did anything examination did it add anything to your history?
So it confirmed that it was proximal, like more involved than the distal, and there was also involvement of the trunk and upper limb muscles.
Okay. Then
It adds on more that the radicals are involved.
Involved. Yes.
Okay. And even the level of the radicals, like history didn't have any upper limb weakness, no?
Yes.
Okay.
Then the answer is right in front of you. No. Told
Like
you that it is a demyelination disorder.
Demyelination is.
How did it tell you that it is a demyelinating disorder?
So demyelination usually involves the nerves with more axon, like the shorter axons. The proximal muscles are more, like proximal is more involved than distal. So that is one. And
The answer is in your diagnosis.
progressive, like
Sensory.
distal symmetrical sense.
So it's not there in your diagnosis. It should have been there in your diagnosis.
No.
So areflexia, no? You got
global. Yes, areflex. Yes, global.
Okay. So global areflexia is there.
And what is not there? I mean, in your diagnosis, something is not there, which is a cliche for cord cases, no?
With no bladder and bowel. Yes.
Did you mention that in the history?
Yes.
No?
Yes, sir.
Okay,
Yes.
Okay.
So now you tell me what are the features of demyelination versus axonal. You have a table in Harrison's.
Yes.
Tell me the table.
So demyelination sensory, like large fibers are more involved, sir, like the vibration, proprioception, and fine touch. And axonals predominantly like small fiber neuropathy, like burning sensations. And distribution, usually demyelinating is symmetric, and demyelinate has mostly acute onset. Axonal is mostly chronic.
Again, you are telling acute. Chronic demyelination also there, no? CIDP is also there.
Yes. Predominantly acute, but axonal is usually long-standing. And wasting is predominantly seen in axonal neuropathy, and generalized areflexia is seen in demyelinating. Only distal areflexia is seen in axonal neuropathy. and proximal more than distal muscle involvement.
Proximal and distal.
Yes.
It's not proximal more than distal.
More than.
So
Okay.
this is one misconception. People keep telling that proximal more than distal. It is proximal and distal. It's not more than distal. CIDP definition of CIDP also. It is proximal and distal. So proximal more than distal.
Yes.
Proximal and distal are happening and reflex happening at the same time. It will tell you it is a radiculopathy and probably a demyelination.
Yes.
Fine. Next.
Okay. How would you approach the patient now?
So approach like.
Oh, it's very good. You diagnosed the patient. So what would you approach? Patient came, he's in your ER, he's admitted from the ER.
Yes.
Now what would you do?
Investigations are like workup, like to confirm the diagnosis. We do general blood investigations like complete blood picture and the renal function test to see if there is any dyselectrolytemia, and predominant main investigations would be nerve conduction studies and CSF analysis. CSF analysis would show albuminocytological dissociation and
2 days.
2 days. Okay.
It's only 3 days, no?
3 days, yes.
Okay, why albuminocytological dissociation? What is albuminocytological dissociation, first of all?
Usually, when the cells are usually there is increase in cells and proteins together in infectious conditions or inflammatory conditions. But in this, the albumin, the protein content is more increased when compared to the cell content. Albumin is predominantly involved than the cell. So albuminocytological dissociation is seen because radicals are bathing in the CSF, so which will release the due to proteins are being released from the nerve cells into the CSF, so which causes increased protein levels.
Okay, now membrane to CSF. Okay, fine. Okay, so you do CSF. So do you, any classification methods for any named classification? You heard of any Brighton's classification?
Yes, sir. Previously it was Aspen. Now Brighton's classification, it is like 3 levels, clinical and investigations, and to rule out other causes. So clinical, it would be acute flaccid paralysis with a reflex.
No. Let's come from behind. What do you rule out? What do you rule out?
Rule out other possible causes.
What possible causes are others? You told already. CPP and ఇంకేం చేస్తాను?
Dyselectrolytemia. Like
what dyselectrolytemia?
Hypokalemia or
so rule out your hypokalemia. That is the first thing. Okay. So investigations, as you told, it is only CSF and NCS. In CS, because you are at MD level, you have that table now in Harrison, which says what are demyelinating features, what are axonal features. They might ask you that.
Yes.
Where is conduction velocity decreased?
Yes.
Where is CMAP decreased? They'll ask you that. Okay.
Yes.
So clinically?
Clinical, there's acute flaccid paralysis with areflexia, sir.
Areflexia. Okay. So you have only clinical findings. You don't have any investigations. Can it be GBS?
Possible.
It can be GBS. Okay. You don't need proof in the first fight because CSF changes and NCS changes take a while. Okay.
Yes.
So if you're clinically sure and there's no bladder involvement, you can proceed with your diagnosis. Okay.
Yes.
Right. So now how would you assess the patient? Now you're daily coming for rounds. How would you assess the patient? What would you ask?
Check for the progression of symptoms or improvement of the symptoms. Like, was it progressing or it is static or it is decreasing?
How would you check that?
So there's
you can't ask the patient if it is progressing or not. So what would you check? Just now in the patient, you've seen lower limbs and upper limb involvement also. So you check the power.
Yes.
What's most important when you shift the patient to ICU or when he's in an ICU? What do you check? Give it a single thought.
Single breath counts or like
single breath count. Okay. Yes. Okay. And what else do you assess? Swallowing. There can be bulbar involvement.
Yes.
And why do you put this patient in an ICU even if he's not having much of all this?
There is a
Because
chance of
you look for autonomic
autonomic.
fluctuations. Yeah, so you have to be careful. Have you heard about the 20-30-40 rule
Mm,
in
No,
GVS?
no, sir.
Like if the vital capacity is less than 20, if the inspiratory pressure is 30, and if the expiratory pressure is 40, then you tend to electively intubate the patient. Okay.
Yes,
Okay. So you do an ABG daily if
yes.
he is going into this thing. Okay. How would you treat the patient?
It can be either plasmapheresis or IVIG, sir. IVIG 2 mg per kg over 5 days, or
IVIG, IVIG, IVIG,
IVIG 2 mg per kg,
2
2
mg per kg, yeah,
2 grams per kg over 5 days, sir.
over 5 days, 2 grams. Okay.
Yes, 2
What is
grams.
IVIG? What is IVIG? Expand it.
IV immunoglobulin.
Okay. You know the mechanism of action?
No, sir.
No, there are 5 mechanism of actions for IVIG. If you're presenting well, they'll ask you this, okay? How would
Yes,
it neutralize? How would it decrease the complements and all? Do read up that, okay?
yes,
The other
yes.
option you told, what is it? Other than
Plasma,
IVIG?
plasmapheresis, sir.
Okay. So now you have both IVIG and plasmapheresis. Which one would you prefer?
Sir, if we do plasmapheresis first, if it doesn't work, we can go for IVIG. But if you're doing IVIG first, we can't go for plasmapheresis later because it removes all the IVIG that we have given previously.
Gotcha.
So
Okay. Okay.
plasmapheresis is better than, like, firstly can be tried than IVIG if both are available.
Okay. No, the saying is like if it is already the 3rd week, then plasma exchange is superior. But as such, in a GBS patient, IVIG and plasma exchange both are equally
Equally
efficient.
effective.
If they're
Yes.
asking, if it is a late presentation, then plasma exchange can help over IVIG because IVIG tends to take some time for acting. Okay.
Yes.
Okay. And variants of GBS? Forgot asking you this. This is important.
AIDP, sir, acute inflammatory demyelinating polyneuropathy, or
Uh-huh.
Miller-Fisher variant.
Okay.
Aman and Amson's acute motor axonal neuropathy and motor sensory axonal neuropathy, or it can be pure paraplegic variant or autonomic variant, or it can
Okay.
be
Very good.
focal variant.
Okay.
Um,
There's one important PCB, cervical brachial variant.
okay.
Okay. And what can I mean according to Harrison, what are the differential diagnosis for a GBS? You have that last paragraph in Harrison, no, which says what is the differential for GBS. He'll mention you on metabolic cause
Thyroid
or Friday.
porphyria, yes.
These examiners they read and come, no? So they'll ask you this.
Okay.
Okay.
Yes.
So most common side effect of IVIG?
Mm. And forgot actually everything.
ఇప్పుడు సీజన్ అబ్బా వాట్ సీజన్ ఇస్ నో ఫ్లూ
Flu, yeah.
ఫ్లూ లైక్ ఇల్నెస్
Flu like
ఓకే
yes.
ఓకే సో what's the prognosis of GVS? Is it good? Is it bad? Is it poor?
Good prognosis if there
Good
are no other.
prognosis.
Yes.
Yeah, generally it tends to have 85% good prognosis. Okay.
Yes.
Okay. And what else? So how do you take care of the patient other than giving them IVIG and all? So you daily count, you take your single breath count, you measure the what do you call power of the muscles, you test the swallow, and
If required, ABG required daily.
okay, okay, and
Physiotherapy, sir, and like ambulation, so with support to prevent the
oh,
complications of chronic bronchitis.
very good. Mention such terms. Okay.
Yes.
Mhm.
Physiotherapy.
Yes, and DVT prophylaxis if needed.
Yes.
Okay. Mhm. Okay. And there are classification systems, no, like that Brighton's classification. There's a scale,
Yes.
cube score, and all.
Cube score.
Like, how do you measure? Yeah, make sure you read all that up.
Yes.
Okay.
Yes.
So
Ram sir?
what is the natural course of GBS?
So it usually progresses up to 4 weeks, sir, but it keeps static after 4 weeks, and then
Okay, this patient will come to you and tell that anyway it is going to be static. And it will progress and it will stop. And then it will decrease, it will improve by itself. So what will you tell them? Whether to take patients. So why should I spend so much money on IVIG? It will anyway decrease. So when do you train the patient? CBS patient, when do you?
Sir, if it is rapidly progressing or if it has already involved the respiratory muscles,
Till you wait till the respiratory muscles are involved. This patient's respiratory muscles are not involved.
yes, sir.
Then you will not treat this patient.
But there are poor prognostic factors, like if there are extremes of age, or it was preceded by a GI illness, or there was a rapid progression, or it was autonomic involvement was there. So in that cases, I think prognosis is bad, sir. So in that cases, you have to insist
for only bad prognosis patients will wait. Good prognosis patients will not.
No, sir. But
it will decrease the disability, no?
Yes.
So basically, when the patient is difficult, has any disability, you do this 6-meter walk test.
Yes.
Patient has mild weakness, you can still wait, or just the patient weakness, you can still wait. If it's having disability in walking, then probably you should start treatment. So obviously, all these things that rapidly progress in extreme ages, respiratory muscle, then you will anyway treat. Okay. So only if the patient comes with mild symptoms, whether you treat him or not, how do you decide? You wait till the patient has disability.
Yes.
Since we are in India, cost is also important. 3 lakhs can throw them into poverty.
Yes.
Okay. So you need to know this also. If patient can afford, then you'll anyway offer.
Yes.
Mild weakness, you can wait till patient has disability. Mild weakness and it is not progressing. You have seen patients who were presented with mild weakness, then they did not progress. You waited. Then it resolved on its own. Okay.
Yes.
Anything else?
If someone else is starting.
Hello, sir. Sir, how many days we can wait, sir, for IVIG treatment?
That's what you can wait.
You should rate of progression is what you see generally, and the affordability of the patient.
So patient is
in India
progressing rapidly, or patient has disability at the onset, then you don't wait. Patient does not have any disability. Disability in the sense that 6-meter walk test is there. So if he is able to complete walking for 6 meters, then probably you can wait. If patient is not affordable. Patient is affordable, he is fine, well to do, then you can start. You don't have to take risk. Patient is not affordable, you can do that 6-meter walk test, and then it is fine. In Miller-Fisher variant, usually I don't wait, because Miller-Fishers, they'll have autonomic disturbances. 17 to 20% of the patients, they have autonomic disturbances. We had a patient who died suddenly. He presented with ataxia and this ophthalmoplegia, and then he had a cardiac arrest. So Miller-Fisher, I don't wait. Even if they don't have disability, we'll give. But others, you can do a 6-meter walk test and then decide.
Okay, sir. Thank you.
Okay. We'll wind up, sir. Nice presentation.
I think it was a good presentation. You have your slides were very clear, and you have read the point.
Yes. And make sure you read all the causes of myelopathy, all other causes of paraparesis. They'll jump into cord and ask you cord-related questions. Okay.
Yes.
So just because it is a GBS, because in DNB you don't tend to know which case you have. So they'll jump into and ask about transverse myelitis, everything. Make sure you read the causes of transverse myelitis. And don't just mention words like subsystemic vasculitis. Mention all. They like listening to terms like, as sir mentioned, they like terms like mixed connective tissue disorder, Sjogren's syndrome, neurobasics. They like all these. And they'll definitely ask you about toxins. Some toxins which can cause myelitis and all. So you'll have to read up all those. Okay, that Harrison table is there, no? Where in peripheral neuropathy, he'll classify everything. And in card, he'll specifically mention where and what. Please read up that. Okay.
Yes.
Okay. That will help you.
Yes.
With respect to
What he,
physio and all, you're very good. That's good. Because reflex arc and all, you at least attempted. Generally, medicine PGs tend to like they fluke around, but it's good that you're reading physio also. Physiology.
what clinical textbook you're reading? Clinical for neurology, anything. If you're a reader, then Dijong you can get a good book. Dijong, you should start with Dijong. If you're a reader, you're just reading for the examination, then whatever book is fine. Examination you'll anyway fine.
Because
You'll
stuff.
anyway pass.
No, if
Becker
it,
staff is fine. But Becker staff, see, Becker staff is one book
doctor
that you should carry in your bag.
pocket in the apron. That's it.
That book. So you should carry. I used to carry Becker stuff in my sling bag. In Dijong, I used to have it in my room and study. Dijong is one book for neurological examination. If you are interested and you are a reader,
Yes.
then you should read that. Becker stuff you should carry with you. So that how to examine the muscles, how to examine the sensory system, all these things you can quickly refer from Becker stuff.
Yes.
It's 2 weeks. Yes. Yeah.
Okay. And read up drugs causing neuropathy. Okay. They'll ask
Yes.
you.
Okay.
Okay. Okay.
Yes.
Okay,
Thank you.
Akif ji. Yeah. Nice presentation. Akif, you're there?
He is not there.
Okay.
Okay.
Okay. Right. Bye.
Thank you.
Thank you, sir. Thank you, Ram, sir.